Hi. Ashok, I am not able to use caster. It is too late. I will just use the normal standard.
Okay.
Yeah. Good evening, everyone. We are live on Ortho TV. I on the webinar of management of osteoporotic fractures, and I hand over to Dr. Grace for taking over the proceedings.
Thank you, Dr. Neeraj. A very good evening and warm welcome from Sanofi to our eminent speakers and all the respected medical fraternity who have joined us today. So I'm Grace Sam, working as Medical Affairs Associate in Sanofi for Sanofi Nutraceuticals Division. So the topic of our today's discussion is a very relevant topic, as Dr. Neeraj mentioned. It's on the management of osteoporotic fractures and the role of vitamin D in the management of osteoporotic fractures. So as we know, in these lockdown times, it's very evident that people are lacking the sun exposure, and thereby the levels of vitamin D is very low. And also, a study in China has shown that there is a more incidence of osteoporotic or fractures during these lockdown times. So this webinar is conducted in association with IORG, Indian Orthopedics Research Group, and as mentioned, Ortho TV, which is the largest orthopedic platform. So we have with us two of our eminent orthopedicians, Dr. Rex Chandra Bose from Rex Hospital, Coimbatore, and Dr. Sujit Jha from Max Hospital, Gurgaon. So firstly, we can hear from Dr. Rex on the management of osteoporotic fractures for a good 20 minutes, which will be followed by an insight into the role of vitamin D in the management of osteoporotic fractures. Later, we can have our questions addressed by our respected speakers. So you can post your questions on the Q&A panel at the bottom of your screen. So before we start with Dr. Rex session, so I would like to introduce you to Dr. Rex. So Dr. Rex is an MS in Ortho, FRCS from MCH, and FRCS Trauma and Ortho from UK, and also has a PhD and DSc in Ortho. So he's a chief consultant, orthopedic and trauma surgeon, head of Department of Orthopedics, Rex Ortho Hospital. So he has a team of 11 orthopedic doctors along with him, and also other doctors. So Dr. Rex is serving as the president, Indian chapter in Institute of Biomaterials, Tribocorrosion and Nanomedicine in USA. And he has also been the past secretary of Coimbatore Orthopedic Society and editorial board member of the official Journal of Orthopedics and Journal of Joint Surgery. So he has been a teaching faculty for many years, and he has been the regional and he has participated in regional and national orthopedic conferences on various topics. The doctor is also an associate member of AAOS, that is the American Academy of Orthopedic Surgeons, and also SICOT World Congress and British Orthopedic Association and Royal College of Surgeons, Edinburgh. So he's currently the reviewer of IA journal articles for publication. So Doctor has authored 2 books, and he has various national and international articles published in peer-reviewed orthopedic journals to his account. He is a great orator, and he has conducted 250 orations and lectures in both national and international conferences. So we are very privileged, Dr. Rex, to have you today on our panel. Thank you for accepting our invitation and being here. So I hand over the session to you.
Thank you very much, Grace, for your graceful representation and telling me some few words about me. And so this is a difficult time for all of us, and we all been flooded with the knowledge through webinars, and definitely I'm sure a lot of people have been have listened to lectures on osteoporosis and fragility fractures and so many topics related to the geriatrics. Now, my present talk is going to concentrate mostly on the orthopedic management of osteoporotic fractures. So let me begin with the management of osteoporotic fractures. Is my slide moving? Can somebody change the slide?
Dr. Rex, you will have to
Yes.
reshare your screen. Please
Oh, I see.
reshare your screen again. Yeah.
Okay. Is it okay now?
No, you have to go to the Zoom window, click on share screen again, go to where you can see the video of yourself, click the share screen button, and then select your PowerPoint.
1 second, I'll do that.
Dr. Rex, can you see my video on your screen?
Yeah, I can. Yes.
So below that, if you see at 6 o'clock position, there is a share screen green button. Do you see that?
Um, Mute.
And
Stop
on the right side,
video.
go keep on going,
Yeah.
mute, and then
Okay.
share screen button.
Okay. Yeah, yeah.
Yeah, the click on share screen and then select, then you'll be able to see multiple windows. Are you able
Yes.
to see it?
Yeah, I
Then
can.
you select the PowerPoint window. Once you have selected the PowerPoint window, then press the blue share button. Yes. Now it has come. You can do the slideshow mode and then start.
Okay. Okay. Thank you. Is it okay now?
Yes, it is working fine.
Okay. So to start with, I'm as an orthopedic surgeon, I'm going to discuss mostly on the surgical management of the fragility fracture. What is fragility fracture? One may wonder that it is not a normal traumatic fracture which we come across. I mean, these fractures are something I say is a pathological fracture. Our bones are not able to take the physiological load or something, just beyond the physiological load, like fall from standing height or just a simple trivial fall with low velocity. You get into the patient gets succumbs to a fracture, and this is very common after the age of 50. And one out of two women and 1 in 4 men after the age of 50 will suffer from a fracture in the remaining lifetime. So which is a huge number, and is going to be a big burden in the society if we don't address these problems or prevent these fractures. And definitely, I would say, if the patient has a fracture and is coming, you're seeing the patient now, there is a 2 to 5 fold risk of getting another fracture in few years' time. So these fractures must be treated very energetically and also must be addressed to such a way that they don't get another fracture in few years' time. So we need to address both the problems, present problem and the future problem. So the common fractures which you see in the fragility fractures, the axial skeleton, obviously, the vertebra, and also the lower limb is more succumb to the fractures like hip fractures, and you see sometimes the periprosthetic fracture, the distal radius fracture in the upper limb, and the proximal humerus. So all these metaphyseal weak areas are prone for fracture. For optimal care of these patients, one must have a goal and also how we are going to reach the goal, the challenges what we face, and also the solutions. What are the solutions available, and how we are going to manage in each phase. That is very important. The foremost important thing in seeing a patient with a fracture coming with a hip fracture is how to keep this patient alive. That is very important because these patients might have had a fracture because of some giddiness or some sort of medical problems, or maybe because of hyponatremia. So many reasons are there why they could have had a fall. And these patients, when they come late to us, especially if they come after 2 or 3 days, they may be dehydrated and they have, completely all the hemodynamics would have changed. And you need to make sure that these patients' medical condition is optimized before you take them for surgery. So, acute management is mostly medical. So, keeping the first and foremost thing is how to make the patient healthy and optimal, optimizing the patient to take them for a fracture fixation. The second thing is only the fixation of fracture. The fracture fixation obviously is a surgical challenge, which I will tell you in a minute, in a few slides later. What are the surgical challenges which you're going to face? And then I'll discuss about the mobility. The most important thing, these patients, when you operate, you cannot make them to say that they cannot put weight and walk for 6 weeks or 8 weeks time, because these patients need to walk, putting full weight on that leg from day one. Very difficult for an elderly to hop on the ward or to walk without any support. So make sure your fixation is stable enough to make the patient to walk at the immediate post-operative period. Once you make them on their feet, all their metabolism will come back to normal. Once they are bedridden, all the problems will start. Like they develop a chest infection, urinary problems, bed sores, the conscious level comes down, they get confused. So all these problems will start once they become immobile. So mobility is the key. And I would say in the olden days, we used to say it is an emergency when you see a fracture neck of femur. Within 24 hours, we need to operate. But I think nowadays the strategy is changed. Once you optimize the condition of the patient at the earliest possible, I would say it's a semi-emergency now to operate these patients at the earliest possible and to keep them mobile. Of course, once you treat these patients, you need to treat the osteoporosis as well to prevent second fracture. So coming to the medical management, let me make it a bit more elaborate. What are the problems which we may come across? So these patients, always I tell my residents, when a patient comes with a fracture, don't have, look only at the fracture. And you may burn your fingers by, treating only the fracture. You are treating the patient completely as a whole. So it is like our father or mother, to take care of the patient as a whole, not just the fracture alone. So to make them all right, they may have some cardiac issues, like the patients coming at 70s and 80s with a fractured hip. They will have some cardiac problems, which you need to assess. They may be on some medications like blood thinners, so which you need to make sure that either you need to stop or can have a consultation with geriatrician. They may have a renal disease or bronchial asthma, COPD, uncontrolled diabetes, hypertension, and they may have a dementia or Parkinson's disease, and even alcohol abuse and whatnot. So many problems may be there in their background. So everything you need to address and make sure they are fine. I've also seen patients who get confused and they have a fall and they come with a fracture, like patients who have a hyponatremia. They get confused at home. They have a trivial fall and they get a hip fracture. So, or there may be early CVA or a transient ischemic attack because of they would have had a fall, and you cannot ignore that. You need to treat that energetically rather than treating the fracture. So, getting into the history in depth and getting the physician involved in the management is very, very important to get a good end result. So the judgment is important when to operate, and always say all these elderly patients must be operated by the senior most surgeon, because the time matters. How how fast you do a procedure matters, and you want minimal blood loss in theater, and you don't want a big surgery, how we're running hours together with a lot of blood loss and hemodynamically disturbing these patients who are already running on a fine balance. So all these are important. So you need to make sure that you have a good geriatrician to take care of the medical problem, and a senior most surgeon should operate. It's not for the young trainees or the inexperienced surgeon to operate. And definitely, if you have any complication in theater, very difficult to come out, and it's sometimes literally impossible. That may be the end of the story. So make sure everything you get in the first time, very good. So that is very important. So perioperative management is very, very important. And as I said earlier, this is a holistic approach. It's a multidisciplinary approach. You need to make sure that you involve your anesthetist, assess properly, a cardiologist, geriatrician, an internal medicine team, and it's orthogeriatric care, which plays a big role in the management of osteoporotic fragility fractures. And as a team, if you work, I'm sure definitely you'll have a good result. So though it may look initially maybe costly when you have a team to work on, maybe in the immediate post-op, they may require 1 day stay in the ICU. All those matters. But if you don't do that, you run into trouble, then this patient may end up in a stroke or MI in the post-op, and it will take away all your the patient's economy. So quality service is definitely cheaper. So you make sure everybody are involved. Don't worry about the expense at this stage. So how to fix the fracture? So this is our role of how we manage the fracture. So once you make sure the patient is optimized and getting ready, got them ready for the theater, and anesthesia, all the medical clearance has been given. Now the patient's coming to orthopedic management. So what is the biggest problem which we face in orthopedics is it is not like the normal fracture what we fix. These patients' bones are very fragile, very weak, and these screws which hold these fractures, it is like putting a screw on in a butter. It's not like in a wood. So the holding property of the screw may not be good enough. So you need to make sure that you get a stable, good rigid fixation for the patient to walk. So you need to use all the latest armamentarium available in the market to make sure that the fragility fracture has been fixed properly, and you need to make sure these patients are able to walk from day one. So the decision making of how you're going to fix the fractures are very, very important. And many times, as I said earlier, the cancerous bones, they fracture very easily, and they always create a void after reducing the fracture. And we need to discuss how to manage the voids. So as I said earlier, the surgical, there are various surgical options in management. The surgical implants, the latest implants like the locking plates, which is a big boon in the management of osteoporotic fractures, because the pull-out strength of the locking plates are very good, and it can withstand a lot of 3 times or 4 times the force of a normal plate. The fixed angle plates, always we prefer intramedullary nails rather than a plate, because it's a load sharing device. And also you need to make sure the fixation is stable enough. So it's not just the plate alone, it can fix give strength to the bone. Or also you make sure that intrinsically the reduction is stable. So that is very important. Making sure the environment on the bone, the quality of bone there where the fracture is also adequately giving stability. So in that scenario, sometimes we need to use bone grafts. So the bone grafts matrix will give some stability at the fracture site. Sometimes we use the bone graft substitutes, which are the biocomposite material like hydroxyapatite or tricalcium phosphates, all those which can be used as a fillers to give strength to the part which we are fixing. And also sometimes we use bone cement. Bone cement is nothing but a polymethyl methacrylate, which will set immediately at the fracture site. So, or to augment fixation with the plate and screw, sometimes we use bone cement as well. So we have various modalities of management of these difficult fractures. And sometimes if you feel that this fracture is not fixable, then you will go straight away with replacing the part. That's what we call as an arthroplasty. So decision making, whether you're going to fix this fracture or you're going to do an arthroplasty in a juxtaarticular fracture is very, very important. And as I said earlier, the long bone fracture is very easy to treat with intramedullary nails, but the metaphyseal fracture is always tricky. And if it's too much fragmented, arthroplasty may be a better option. But if it is fixable, we try to use locking plates and also augment with hydroxyapatites or fillers. So some of the few examples I can say, the fracture neck of femur, all the time we try in the elderly, we don't fix it. We replace the ball. Either you do a cemented bipolar or you do a totally arthroplasty. And similarly in the shoulder, 2 or 3 part fractures, definitely locking plates is very good. When it comes to 3 or 4 part fractures and 4 part fracture dislocations, maybe reverse shoulder arthroplasty may be a good idea rather than fixing the fracture, which may go for avascular necrosis or non-union, implant failure, and all sorts of complications. So that is very important. So arthroplasty is definitely an alternative way of managing a hip fracture, and there is no controversy regarding neck of femurs. Definitely need to go for a, hemiarthroplasty. But nowadays, if the patient is very active individual and being elderly, sometimes you need to consider totally arthroplasty as well. And definitely is increasing in all the European literature. They are doing a total replacement for fracture neck of femurs. And if you see a fracture like this, with the trochanteric fracture, with the neck fracture, in young patients, definitely we'll try to fix. In elderly, I don't want to put a intramedullary PFN proximal femoral nail because sometimes it may pull out or it may break or it may not the fracture may not heal because of the type of fracture what you see. And here, straight away you can go for better to go for a hemiarthroplasty cemented and fix the trochanteric fracture. But one must understand the converting a trochanteric fracture into a hemiarthroplasty or totally is a bit tricky and is time consuming and a lot of blood loss is necessary will be there, and only the senior surgeon who is experienced should venture. Is not for the junior most to go for a totally for a hemiarthroplasty because a lot of work need to be done without much of blood loss. And as I said earlier, the arthroplasty is not, rosy all the times. Sometimes, while doing arthroplasty also, you can get a peri-implant fracture on table because these bones are very fragile, and any twist or turn when you put a long stem can, go on for a problem. So always you should have a revision components ready when you go for a primary arthroplasty. So the complications are quite common when you do a arthroplasty, and one must expect and also make sure that you don't get into trouble. And as I said, shoulder, definitely nowadays anatomical shoulder replacement has been replaced by reverse shoulder arthroplasty, and all the four-part fracture dislocations, straight away we do reverse shoulder arthroplasty. But three and four-part without dislocations, definitely I'll try to reduce and fix with a Philos plate. And the again another example of a bag of bones distal humerus fracture, where definitely you need to go for a replacement is a better option rather than fixing all these bag of bones with a lot of plates and screws. And this is the Philos plate, as I mentioned earlier. This is a fracture neck of humerus. The locking plate has really revolutionized the management of proximal humerus, and is a wonderful way of dealing with this sort of difficult fragility fractures. And easy to move the shoulder from day one. The shoulder doesn't get stiff at all. And one must understand that the concept of locking plate is it is something like an internal fixator. The screw heads get locked in the plate. So the pull-out strength is very good, not like the ordinary plate and screws where the friction between the bone and the plate, decides the stability. But in locking plate, it's not so. So it is not necessary that the plate should get abutted on the bone, and it's something like limited contact, it works. So what is the principle in a periprosthetic fracture? I mean, many times nowadays we see a lot of elderlies, they go for arthroplasty and they have another fall and they get a periprosthetic fracture because the weak junction between the prosthesis and the bone, which is the elastic component and the stiff component, that junction breaks. We call this a stress rising phenomenon, and it's very difficult to treat. And if the component is loose, obviously you go for a revision arthroplasty. But if the component is well fixed and the fracture is below the component, probably you can save the component. And always you try to put as a big spanning plate like this, and avoid stress rises. Always bicortical fixation and a long plate through and through. Fixing the plate, the bone is very important to provide another stress rising point. These are the difficult fractures. I can see this lady had 5 times operated revision hip, and after she after 20 years of my revisions, she again had another fall. She just broke a supracondylar area, and I don't think I can do anything by revising the arthroplasty, but I thought the simple way is using a long locking plate with the possible screws in and around the process, and the circlage wire. Definitely here it worked well, because around the Wagner stem there is little bone left, and the circlage wire made the trick to fasten the fracture and made to heal. And sometimes you see peri-implant fractures. This lady had a 3-time operated for a proximal femur, and she was doing wonderfully well. But 6 months later, after the DHS, she broke just at the tip of the plate. And here is a difficult scenario, because we is only 6 months down the line following the proximal femur, which were fixed. So we thought we'll go for a retrograde nailing, missing the screws technique, and we removed few screws and then used circlage wire and put a longest supracondylar nail to span across and made it to heal. So all these are very tricky and also energetic procedure. Sometimes is a lot of blood loss. So all these you need to think in mind when you do these sort of procedures. So the current implant options in a peri-implant fractures, the Zimmer has come with a non-contact bridging periprosthetic system, and DPO has come with the locking attachment plate, which is really good. And the Accord cable systems, we all know, very familiar, the Smith and Nephew plates. This is the non-contact Zimmer plate with a variable locking. And the good thing is you have anatomical plates with the peripherally placed locking screws, so it can miss the intramedullary, the stem, the femoral stem, and the locking screws can go all around, just like hugging the prosthesis, and we can get good fixation with, along with the circlage wires added up as well. So, which is really good. And the circlage wires nowadays can be attached to the locking screws, as you can see in the diagram. So it's a cable circlage system, which is really good. And this is the diffuse uh, attachment plate, we call, is something which is like a butterfly plate, which can sit on the top of the locking plate, anywhere, wherever you want to. You can fix this butterfly plate, and it has got screws. You can see you can have 4-hole or 8-hole the attachment plate, and it embraces the processes from the side, and it's nicely fixes the, you have a sometimes bicortical good fixation to go around, and definitely it's a wonderful type of fixation which you can achieve in a difficult periprosthetic fractures. And the cable system, we all know, we are very familiar. This cable system goes with the plate, and initially we have used Dahl Miles plate. Now the Accord cable plate, which is very strong and is a crimping mechanism. We can loosen and again retighten if you want to. And it's not a simple wire; it's a cable, the multi-filament, which is 4 times stronger and than the simple cable which we use. So it's a good system, and also for long spiral fractures, really works well. And what is the other thing which we have in the screws? Nowadays, we have a hydroxyapatite coated screws, which will augment the fixation in a weak bone. So the bones can grow in and fix on these screws. Sometimes it's very difficult if you want to remove these hydroxyapatite screws. There's normal standard screws, you get osteolysis around the screw threads because of the micro movement. But here, the hydroxyapatite coated, you can see the bone is ingrowing onto the screw. So it's an on growth which happens around the screw. So the pull out strength of the screw is very good. So what are the void fillers? So now you saw a different spectrum of fixations, and what are the different plates available in the market for fixing all these difficult fractures. And for void filling, as I said earlier, many times we use the polymethyl methacrylate, but autologous bone graft is the cheap and easy way of carrying out the filler as a filler, but sometimes difficult in a big gaps or big voids, and biocomposites like putty, which we mix and fill the gaps. This is the fracture trochanter, and it's been the putty which has been injected and which sets hard. And again, the tricalcium phosphate cement augmentation to fix the fractures, which gives immediate stability for the fracture. And especially in metastatic bones, it is really wonderful. So we get a good type of fixation. And here, as a dislocated fracture, you can see that to maintain the length and alignment, not only the fixation, the locking plate is of good use, but also to fill the voids, to prevent loss of length, and also to increase the grip strength. It is really important to fill the gaps with tricalcium phosphate putty. And this coming to the spine fractures, and only few patients for the commonest the thing which we use for fixing these fractures, the spine fractures, is a vertebroplasty or a kyphoplasty. So filling the void of the crushed bone, it can be with the cement, which we call as a vertebroplasty, where with the high pressure you inject to get the height of the compressed vertebra. But if you use a kyphoplasty, which I will show here in this picture, and here you can see this is a balloon which is will which goes into through the pedicle, and when you inflate, it get the height of the uh, spine, and once it got inflated, then you use the low viscosity cement to inject there, and then fill the gap like this, and you restore the height of the vertebra. So the most important here in kyphoplasty is good relief of pain. The patient, it's like a magic. They feel the back pain disappears, and it's really good, especially in acute scenario. If they have a lot of pain, it really works wonderfully well. And the recent evidence shows the randomized control trials between the vertebroplasty and the kyphoplasty. And they said the kyphoplasty is a better option than the vertebroplasty in terms of maintenance of the height and the pain relief. So vertebroplasty is less preferred than the kyphoplasty. But one should understand it is a tricky technique. And if this dye or the cement extravasates, you are into trouble. If it extravasates into the spinal cord, you get a paraplegia. If it extravasates into the major vessels like the aorta or the IVC, you are in trouble. So you need to make sure that you are in the right spot. And coming to the medical management, now we have discussed a lot about the surgical management. But to finish my talk, I thought, as an orthopedic surgeon, what I will do to my patients in prescribing what medications for these patients. So theoretically, reducing the bone turnover by anti-resorptive drug is the first line of management, which we all do. There are a lot of clinical trials are there to say that anti-resorptive drugs definitely work and also helps in fracture healing. And there's no immediate, it doesn't impair fracture healing. I can put it that way, because the alendronate sodium or the bisphosphonates which we use definitely will decrease the bone remodeling capacity, but the fracture healing is never been stopped. So the remodeling of the callus there may be a delay, but this is only in the long term. As I say, like 12 to 18 months, the remodeling capacity may be delayed because the anti-resorptive drugs, but the bone fracture healing and the recurrence of fracture is definitely less by using anti-resorptive drugs. And definitely I practice by giving my patients one shot of zoledronic acid injection in the immediate post-op. So that solves the issue for next 1 year. And patients who can tolerate or who prefers oral, probably weekly bisphosphonates is the drug of choice. And so you strike a balance between the formation and the resorption of the bone. So the bone remodeling, look into the which is the best way of management. But if I use unsymmetric processes, I prefer the bone forming drug like teriparatide so which is a bone forming drug, which definitely it increases this got an anabolic effect on the bone, and we know the paradoxical effect of the PTH, which is the teriparatide. When given independently, it forms the bone, and a lot of clinical trials have said that it definitely works, and we do use in resistant cases as well of this teriparatide. So patients who are already treated on alendronate, on if they succumb for a fracture, and all these patients come repeatedly with this some fractures very often. Probably the second drug which I prefer is a teriparatide, a subcutaneous every day. Um, so coming to the rehabilitation, as I said earlier, these patients must be on their feet on the next day. So very important. If these patients are, again, you keep them in bed after operating, or your fixation is flimsy, and you cannot make them to weight bear and walk on the immediate post-op, then your goal is gone. I mean, you lost the game. So it's a no-win situation. These patients must be mobile on day one to get all their metabolism going in the right way. So make sure your fixation is proper, adequate, strong enough, and get them on their feet, and get your physiotherapist to work on day one. Get their joints moving. At least they can do partial weight bearing with a walker frame, and they get their muscle function back. So that is very important. And if you keep them on the bed for 6 weeks, very difficult. They will never resume their walk at all, and sometimes that may be the end of the story. So discharge planning is also very important in our country. I mean, we have all the joint family system. Does it definitely works well. But nowadays, you see many families, they don't have their sons or daughters with them, and definitely they need to find a proper nursing home care where they can put in for follow up, or you need to have do some sort of arrangements in the post op to make sure that they land up in a good place for good rehabilitation center. Otherwise, all your good work will be lost. So that is very important. And obviously, all my patients have a high protein diet from day one. I do prescribe them on a high protein diet. Vitamin D, always they get one shot. I don't test them on the vitamin D. And obviously, Dr. Sujit is going to talk a lot about vitamin D. So I'm not go into the medical management of vitamin deficiency, but all my patients get one shot of vitamin D in the post-op, and one injection. And then secondary prevention. I mean, all we orthopedic surgeons sometimes we don't give much care about the secondary prevention. But I think as a doctor, we are also bound to medically manage these patients and prevent the secondary fractures. So second patient coming with second time with a fracture is only a mismanagement, and you need to make sure that these patients have a proper prescription of the management of the fragility fracture, including vitamin D, calcium supplements, proper bisphosphonates, or bone forming drugs. All those prescriptions must be given for next 1 year. What need to be done at what time? So, as a doctor, a complete treatment is very, very important. So the fragility fracture is a serious fracture. So it's a challenging aspect for the for both for the medical management as well as surgical management. So if you don't treat them properly on day one, definitely you may have a very bad result, and you burn your fingers. So energetic way of managing these patients on day one as a semi-emergency, make them optimize their medical condition, get a multidisciplinary, give a multidisciplinary approach and workup for the managing these patients. And surgical techniques, as I said, the senior most surgeon should operate on these patients to avoid complications. And you think about the biology, how this fracture is going to heal, not that your implant or your plate and screw is going to do the work. So that is very important. And always think about the secondary prevention. That is also is very, very important to prevent further problems. So I believe that you understood the total complete management of a patient coming to you with a fragility fracture. And thanks for patient listening. Thank you.
Thank you, Dr. Rex, for that very elaborate session on surgical management. Uh, now I would like to invite Dr. Sujit Jha to speak on the role of vitamin D. So before that, I would like to introduce you to Dr. Sujit Jha. So Dr. Sujit Jha is a very eminent endocrinologist. He is serving as the director of Institute of Endocrinology and Diabetes and Metabolism in Max Healthcare Limited, New Delhi, India. He has also been the principal investigator in various clinical trials in Europe and UK. So he has been the director of the CMT postgraduate training program in UK and also the lead examiner of MRCP UK. So doctor has a very extensive experience of 20 years, including 10 years in the UK. And also for the last 10 to 11 years, he has been associated with Max Healthcare. So he has undergone a specialist training in UK for 5 years before embarking his journey in India. So he has guided various master students for their PhD and DNBs. And as I already mentioned, he's the lead examiner. He's also very much into research work. He has been the principal investigator for many trials ongoing as well as completed trials. So he has been the best awarded the best researcher and innovation award at various forums. And also Dr. Jha has several publications in high impact peer reviewed journals, with a few recent publications being in the Nature, the Lancet, and the Diabetes and Endocrinology and Diabetes Care Division of the Lancet. So I think we have a very well experienced and a renowned endocrinologist with us. So over to you, Dr. Sujit Jha. You can have 20 minutes for your session.
Okay. Can you see me? Can you see my slide, Grace? Dr. S, can you see me? Thank you very much. So, Dr. S, I must start that I worked in orthogeriatric ward. I used to work with UK in Cardiff called Professor Johnson. And if I've learned medicine, that's what it is. I work a part of a 6 months geriatric rotation work for 2 months. Honestly speaking, it's a different experience. Even that age, the average age was 75, 80 years old. And, he used to carry gloves in his pocket. He used to carry the gel for the PR, lignocaine gel for the PR, and he used to carry dipstick in his pocket. And he used to carry red pen in his pocket. And he used to check his sodium, urine dipstick, and do PR examination. And he saved large amount of money, and he saved his salary, and that's what his post was created, that he will get all the fractures into the theater as soon as possible, and sometimes on day one. Because as you know, in the elderly ward, sometimes they can stay for a couple of days for little reasons. He'll do the PR, make sure the patient not constipated, urine dipsticks, patient not UTI, and patient sodium and normal chest X-ray, blah, 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 pre-operative tests. He used to get operated that day immediately. So, and at the same time, orthopedicians in UK used to discharge them back and he used to take over the care, and orthopedists to do the normal job, not bother about how the recovery would happen, prevention and prophylaxis. And crossing off medication, because a large number of elderly patients used to a large of medication, they used to cross. That can cause low sodium, as Dr. S was highlighting. So orthogeriatrics is very interesting itself as a super specialist subject, and that in India would need an orthogeriatric physician with the understanding of not stopping surgery and getting them back to the theater so surgeons can operate day one. My understanding at that time, 1960s, the mortality within 1 year was 40% before those days of tying screw and tying those ropes and whatever that is used to be called, is high mortality because of deep vein thrombosis, pneumonia, and UTI. So my understanding of a fracture really changed perspective of why, and I must say at that time, osteoporosis was evolving subject 25 years ago because we didn't have much agent except bisphosphonate. So, and vitamin D was evolving subject as well, and so vitamin D is quite a new area because vitamin D was difficult to do the test. A lot of people ask me, what the hell? And I've been prescribing vitamin D almost 8 years, every patient of my life, the last years on vitamin D prescription. Every patient. I mean every patient, there could be 1 or 2% miss, but default prescription of vitamin D. I'm not really, except, vitamin D toxicity and all that stuff is there. But almost every patient's vitamin D. So vitamin D, I'm a strong believer in osteoporotic fracture, a strong believer that patient should be operated. At the same time, Dr. X said, I could see the difficulty. I work with large amount of orthopedician in Max Hospital, which from Dr. Bajaj to Dr. Maria, so many other people, and even so many of my friends, colleagues, operating this, and Dr. Walia from the spinal surgery operating this. So I do understand there also a fear of osteoporotic fracture as well. So over to, so can I change my slide? Yeah. So I think this is well familiar to everyone. The osteoclastic and osteoblastic activity. Osteoblast forms the cell, osteoclast takes it off. It's a 2 to 3 weeks process, which tends to happen in bone reforming. Otherwise, bone will become very rigid. And this is very famous picture. Why do we need supplement of vitamin D? Now, if a lot of people, I'm sure orthopedics has confirmed that vitamin D deficiency happens to almost every patient, you need to have 20 to 30 minutes exposure, 15% of your body to be exposed between 10 and 2 in Delhi to get vitamin D sufficiency. So 10 and 2, 15% of body to be exposed, 3 days a week will give you sufficient vitamin D. Now, any of us, forget about lockdown, vitamin D deficiency is common because of these. Even for the food supplement, unless certain Western countries like UK have food supplements, milk have what do you call not a supplement, it's a different word for that. Vitamin D is added in milk substances. Otherwise, you need sun from 70 hydroxycholesterol, go to D3 into the liver, D2, D3 converts into 25 hydroxy, and finally to 125 hydroxy vitamin D3. We don't replace 125 because you need to monitor. You can have absorptions going up, you can have hypercalcemia, very common, until has patient has got the renal disease. Normally what we test is D2 or D3. We check 25 hydroxy vitamin D3 because that's more stable. That's what we do. 25 hydroxy vitamin D. We give you D2 or D3 supplements for supplementation of vitamin D. So vitamin D deficiency can lead to lack of calcium absorptions, and that can lead to hypocalcemia. And the calcium is coming from the bones, and that's what it makes mobilization of calcium from the bones. That's what makes you weak and osteoporosis. Osteoporosis is common. I don't know to teach what's the prevalence. You are the one who faces the osteoporosis. What are the fracture risk, mortality, lifetime risk of 53% women and 20% men? Men have increased mortality rates after osteoporosis-related fracture. The osteoporosis decreases your mobility, decreases your cardiovascular outcomes, increases pneumonia, increases UTI, more hospital admission, more fall, subdural hematoma. So people underestimate osteoporosis. Osteoporosis, primary, secondary, and the treatment of fractures is so important because they increases immobility, increases the death rate, causes depression, pain, hospital admission, more care, more cardiovascular. Family needs to be looking after them. So large number of of patients of more than 50 people, women have large number of patients with osteoporosis. Sorry, just a second. Laughing. So a large number of people would get osteoporosis. So, so impact of osteoporosis we already discussed. Osteoporosis prevalence, large number of 50 million individual osteoporosis. India, more than 4.5 million women with the age of 6 years time. Anybody above 50, 65 thinks of bone density scan. Prevalence of vertebral fractures, males and females in India, you can see it's quite high among 70 years old, almost reaching like 20%. And that's one of the common things that what we face in the osteoporosis, the fracture. I tell them, it's you can't look at the building by looking at it, looking at the plaster. You need to understand the bony structure, the rods, how much of rod structures are there. So that's why you need a DEXA scan to understand osteoporosis. Even sometimes X-ray, and sometimes my orthopedician tells me they can feel by screwing the bones, they do understand that this patient was osteoporosis. So low trauma fractures or collapse of vertebra itself means osteoporosis. Prevalence of fractures during COVID times in China, they have been highlighted in importance of primary prevention, which includes home prevention, to measure that a study report China revealed that disproportionate prevalence of hip fractures because of the low standing, poor mobility leads to the fracture. So this is our study that we did study bone density associated with the risk factors of injury. We unusually did uric acid as one of the markers, and that was the prevalence of osteoporosis in 524 patients. This was the risk of osteoporosis. Minded, they are not high risk patients. They were low risk patients who are getting routine preventing health checkup. That was the risk of osteoporosis. That's what we found: 5 to 6% at different age group, and the lumbar spine fractures are very common in our population, and that's what you can see that. And gender-wise, the females have higher compared to females. That was our 540 patient data. We did uric acid as one of my students did PhD and found that high uric acid is protective towards osteoporosis. I'm just saying that doesn't mean they'd stop not bringing uric acid down. Uric acid have got some negative implications as well. So high uric acid tends to protect it, okay? So age-wise distributions of males and females on lumbar spine, or age-wise distribution of osteoporosis, I can see that almost like 36% of both sexes can have, in female, can have osteoporosis in lumbar area compared to 5.6% in males. The key observation that high uric acid levels was associated with higher BMD. That was our key observation, and osteoporosis prevalence was around 7%, female 11%, male 4.2%, and osteopenia 34%, female 40%, male 29%, and prevalence of osteoporosis increases with age, females, but not in all bone sites. BMI weight positively with alphas was negatively correlated with BMD, which is concurrence with widely reported literature. So that was a study which was done along with my colleagues in Max Healthcare. So the low calcium intakes, extensive prevalence of vitamin D deficiency, increasing longevity, sex inequality, no cares in females, menopause, genetic predispositions, lack of diagnostic facilities, and poor knowledge of bone health that's why we have high osteoporosis fracture in our population. This we know, the osteopenia and osteoporosis, most orthopedicians are very familiar with this, with T-scores going minus 2.5s are risk of osteoporosis. So I think just a second. Just a second. I think I just cut and pasted at the wrong place. I'm sorry, because I thought people will ask me questions. I'm not going to talk 250 slides, but I had some of the slides. I thought I'll put it down, and it's gone up in the middle. I'm sorry. Yeah, I'll come back. Yeah, I'll come back. Just a second.
Dr. Sujit,
Yeah.
in the meantime, can I ask questions to Dr. Rex?
Sure. Yeah, you can.
You can sort it out. You can sort this out. I'll just stop your screen share. You can sort it out and take your time. And then you reshare the screen once you are basically done.
So Grace, can you say your slides? Because I think mixed up with slides. Grace, can you do the share slides, and I'll come back to that slide number again while being done? I pasted some
Rex,
at the wrong place. Yeah. Or I'll do that.
Dr. Rex, can you start your video? We cannot see you. Can you hear us?
Yeah, I can.
Your video has gone black. What has happened?
My video?
Yeah, Mala, we cannot see your face anymore. Is there something in front of the webcam?
No. No.
So I would like to ask Dr. Rex. So what is your first line management after an osteoporotic fracture? How soon would you like to, you said there was something about teriparatide and bisphosphonates. So how soon would you like to start teriparatide immediately post-operative? In the hospital
Uh,
or at suture removal?
no, I would say that I don't use teriparatide on day one. I use zoledronic acid injection on the on the day, just a day before discharge. Am I audible?
Yes, yes, you are very well audible, but somehow we cannot see you. I don't know what's the problem.
Uh,
But yeah, we can hear you, so you can go on.
okay, yeah. So my first on the first day of in the immediate post-op, we give one shot of vitamin D, 60,000 units, and then start them on calcium. And the patient has got any renal problems, we start on calcium citrate malate. Other patients get a conventional calcium salts. And then usually the third or fourth day the patient gets discharged. So just a day before, we give one shot of zoledronic acid. And sometimes these patients may get a bit feverish or things like that. So I know 24 hours there is a time for us to watch and make sure they are fine before we discharge. Only patients who undergo uncemented replacements or whom I feel sometimes the bone is too fragile, sometimes like a eggshell. Those patients selectively, I start them on teriparatide from day one. So that is a protocol which we follow. And
Thank you.
So I'm back
Yes,
again.
yes, you
Yeah,
want to.
yeah, I'm back again.
yeah,
So, what are the causes of endocrine causes of osteoporosis? You must say that as a clinician, saying osteoporosis and starting bisphosphonates and teriparatide, sometimes yes, fracture. The question is that there are hidden conditions and you find a lot of amount of hidden disease. I will tell you simple, celiac disease is such a common thing that what we see in type 1 diabetes, we see in common, and that kind of, especially female who are thin, may not have any GI symptoms. So it's very important to say that, even they are presented in 50s and 6 years old. I've seen large number of patients with celiac disease. Forget about Cushing symptoms, hyperthyroidism, hyperprolactinemia, this is erection difficulty, has raised prolactin, diabetes, acromegaly, chronic disease, alcoholism. There are certain drugs like steroids, which everybody knows, heparin, antiepileptics, certain glitazone, pioglitazone, what we use in diabetes, SSRI like antidepressants, proton pump inhibitors. There are other disorders of collagen metabolism and any rheumatoid arthritis, immunosuppression therapy can all cause osteoporosis. But in females, postmenopause is very common, but you meet with at least short history, check calcium, phosphorus, PTH, vitamin D before you jump on any osteoporosis treatment. It's very important to look at testosterone level, rule out celiac disease, look for the thyroid disorders, look for something like Cushing's. I know there are 2-3 patients who have been treated for Cushing's disease, osteoporotic fractures later presented with the Cushing syndrome. So this needs to be suspected. And history remains important. I'm not saying that everyone needs investigation. It doesn't mean that any osteoporosis coming to endocrinologists, we investigate every disease, what's there on the screen. But history remains more important. Understanding for the disease, knowing about this, besides the vitamin D and calcium deficiency, remains the commonest cause of osteoporosis. But sometimes there can be some other disease which can be missed on this. So there's a strong correlation, calcium, vitamin D, correlation between 25% vitamin D and PTH. So large number of patients with a high PTH, it's a population prevalence study. If you do that, once your vitamin D level starts going down, the PTH level tends to go up high. That's a normal reaction that will happen. And if the PTH deficiency if PTH levels are high, it means patient definitely have vitamin D deficiency. If the vitamin D is normal and PTH is high, that itself, and with the calcium low or high normal, that needs to be investigated as well. But you will expect some large number of patients with a vitamin D deficiency with a high PTH. And hip fracture patients in India have vitamin D deficiency and secondary hyperparathyroidism. That's what I'm talking about. At high PTH, it's very common. Alkaline phosphatase can be raised or normal, and vitamin D, which is very common, the PTH level can be in hundreds. And some patients with a hyperparathyroidism also can be seen. So it's very important to understand that patients can also have eukαλcemia and hypercalcemia, so they need to be investigated. Vitamin C supplementation is needed in all population, as I was talking, to prevent the fragility fractures, and who are taking anti-osteoporotic treatment or any treatment of osteoporosis, vitamin D supplementation along with the calcium is required. And people are at risk of reduced absorption of dietary calcium, or people are taking steroids 7.5 mg more than 3 months time, require osteoporosis, prevention of osteoporosis treatment besides calcium and vitamin D. The low vitamin D is despite of abundant sun exposure. Previously, it is thought that Asians have vitamin D exposure, but that's unlike. We need more exposures of sun to create the same level of vitamin D. So across the world, except the paramedic staff, the school girls in Lucknow, walking to school, walking to the rural schools also have vitamin D deficiency. So the whole population, this is the commonest deficiency disorder across the world, because we tend to not expose ourselves. Low vitamin D status, despite of abundant sun exposure, as I told you, we need to have 15% body to be exposed for 15 to 25 minutes time, 3 days a week, to cause sufficient vitamin D level. So in spite of abundance, we still have deficiency, and normal supplement will not make you vitamin D deficient. So I'll come back to that. So the meta-analysis of effect of vitamin D treatment for preventing osteoporosis has all of them shown a positive results. So vitamin D deficiency in 4,000 patients, control 4,000 with decreased bone density, 17 trials, standard vitamin D, 10 trials, hydroxylated vitamin D, 14 trials, and both from vitamin D, 1 trial. There are 25 trials which have shown that most patients with supplementation vitamin D reduces the vertebral fractures and non-vertebral fractures. And vitamin D and fracture trials have shown that French studies, in the nursing home studies with 18-month supplementations of calcium and vitamin D. So basically, I'm not going to nitty-gritty of each and every trial. They have reduced 30 to 40 fracture rates, 25 to 30% of vitamin D. So most studies have shown that if you give vitamin D and calcium supplementations of 65 and 75 plus with an osteoporosis, you reduce the fracture rate by almost 1/3 or more. So you can understand the cost of this. And certain Boston area studies with the 389 community dwelling with women, the 3S trial with 700 IU vitamin D supplementation with the calcium citrate, 60% of all non-vertebral fractures and 60% of hip fractures. So there have been large number of studies which has really improved, and the bone marrow density is improved. So there is no doubt in any mind. It's like an aspirin and heart disease prevention or secondary prevention, that vitamin D supplementations and calcium supplementations definitely prevent the risk of fractures in patients with osteoporosis. There are non-pharmacological therapy for reduced fractures, alcohol moderations, decreased caffeine intake, smoking cessations, calcium and vitamin D, walking at least 8,000 IU per day. We tend to go 3,000 IU per day. Treatment approaches, that's not a topic of discussion today, but that's what there are, as Dr. Rex was highlighting, anti-resorptive therapy, the bone forming like parathyroid, teriparatide, and drugs with a multiple complex mechanism, which includes vitamin D and denosumab. But there are bisphosphonates remains the standard of care in osteoporosis and in osteoporosis treatment. The osteoporosis management, over 75 bisphosphonates with oral bisphosphonates, calcium and vitamin D supplementations. 50, 75 years time, low fracture rates get for DEXA scan, age 65 to 75, T-score less than 5 start bisphosphonates. So there are different stages of treatment. As a clinician, we can decide what to approach. This is a complex slide, but those who are all post-menopausal means with a very high risk of osteoporosis, most, if you recommend, don't go straight to denosumab, but straight go to bisphosphonates and other therapy. But mind it, if the age is higher, 65 plus, and the osteoporosis is severe, you can go to denosumab, but preferred agent, longer term studies has been with the bisphosphonate with teriparatide. There are other agents which can be used along with some therapy as well. So the topic is not to talk about osteoporosis, because that itself is a different topic, and that these are the highlighted blue boxes that you can consider. So how much vitamin D is enough? Should vitamin D levels are measured? Does supplementation vitamin D reduce the fracture rate? If you tell me that do you need to do vitamin levels every patient, as a physician, I'm not talking osteoporosis. General populations, I do not do. I prescribe 30 to 40 a day before fracture, before COVID times. and hardly do vitamin D. If they have taken injections, if they have been taking supplementation, then I do use it. Those who have not been taking, I go straight. You can go up to 1 to 3,000, up to 4,000 IU per day. 60,000 IU every 15 days will not make anybody vitamin D toxic. Now, the question is about injection versus supplementations of oral supplementations. That's what the discussion is about. I'll come back to injectable, because if you give 6 lakh injections, which you give 1675 per day, and the levels can go up and down with the risk of abscess as well. So oral is well absorbed. You don't have to give vitamin D injections in every cases. I know orthopedicians prefer to make sure the bone healing is perfect because of the compliance you see with the patients. If you have no issues with the compliance, I would strongly recommend vitamin D as an oral supplementation in majority of the patients. And the calcium absorption threshold, where the calcium absorption is not affected, is 32 NGTL. Chief dietary source, fortified milk, that was the word I was missing, cereals, egg yolks, saltwater fish, liver, individualized requirement, sun exposure, age, vitamin D deficiency, several other factors in malabsorption, skin pigmentation. So method 25-hydroxyvitamin D in patients who have high risk. If you're not sure about it, you can do it. It's an expensive way. Rather than doing the testing, it's better to do supplementations who have no fracture recommendation, no fractures. Calcium, vitamin D supplementations. This is what I'm sure everybody knows about it. We mainly talk about adult. Average 1,000 mg per day. The postmenopausal to 1,200 mg. During pregnancy is going to 1,000 mg. Younger people require much lower dose, and men require 1,000 to 1,200. So approximately 1,000 mg a day, which is an average calcium requirement. Recommended vitamin D intake is something like, the adults, there are different recommendations, but most people would require 1,000 to up to 4,000 units. I know that different guidelines is different things, but most recommended vitamin D, if you take 1,000 every day, which becomes 60,000 IU, is a good enough for you. Large number of supplementation, especially United States based, have 1,000 IU per day. Some people find that better compliance rather than every 6 weeks for 6 weeks, or every 15 days. But if you can, vitamin D supplementations of 1,000 IU per day, which is good enough, but take it regularly. If you're deficient, you can load it up initially and then go a maintenance dose. High degree of variability in vitamin D content of most available commercial form of vitamin D. And Dr. Khargawat, who is next to us, as in aims that 28% formulations were within the accepted range. So only 30% of the vitamin D supplementations has sufficient vitamin D. The rest 70% didn't have sufficient vitamin D3 content. That's important. And there are millions of brands in the market now. So vitamin D3 formulation with a nanoparticle is solubilized vitamin D3. The size is small, but less than 150 nanomolecules. Surface is attached with a polar head group, making them highly hydrophilic. Minded, they are all soluble, so they're hydrophilic in nature because of the nanoparticle. Surface charge modulated zeta potential make it more stable compound. Delivers vitamin D3 directly at the site of absorption without depending on lipid digestion process. Absorption by different pathways, good biolevel and good compliances. And conventional formulation versus the nanotechnology base does not depend on the lipid. Time of the injections can be taken any time of the day, less GI effect, malabsorption patients, no dietary restrictions, can be taken. You don't have to take with milk or yogurt. You don't have to have alkaline or acidic medium effectively. So the absorption, the bioavailability, the compliance of vitamin D with an actual nanotechnology is much better. There are few firms besides Nupura who are into this nanotechnology, which is helping a better vitamin D absorption. Based on Dr. Khargawat's studies, almost 1/3 of the supplementations are not good enough. It is a nanolipid particles, usually aquosol containing, as already discussed, as a better absorption rate. And there's what's called IGNIC technologies, which is a novel technology platform to produce biolate tablets containing calcium and nanovitamin D3, which is made it absorbable. And their biolate contains 1,000 IU cholecalciferol in a nanoparticle. That makes it much easier for both calcium and vitamin D to be absorbed as well. So this, how the IGNIT nanotechnology works, that's disintegration of the tablet of calcium salt as well as vitamin D nanoparticle in the GI environment. Being a nanoparticle, vitamin D nanoparticle will rapidly empty it in gastric pouch with absorption of vitamin D3 initiated much earlier than calcium absorption. And in the gastric fluid, the calcium salt slowly dissolves the release and ionic calciums into release into intestinal region. And absorption of nanovitamin D3 helps in absorbing calcium from the intestinal absorption. So that's innate technology. The nanotechnologies have revolutionized the treatment for vitamin D supplementation. So all patients who are not had osteoporosis, high risk of osteoporosis, better to have DEXA scan and risk stratify them. But post-fracture, all of them need a vitamin D and calcium supplementations, and most of them would need a DEXA scan. And if there is a risk of osteoporotic fractures on the vertebral X-ray, you can start bisphosphonate treatment. Make sure some basic work of KFT, liver function test, CBC, and in case of younger age group, they need to be investigated more, including checking of calcium, phosphorus, PTH, and alkaline phosphatase. So I know there will be a lot of questions. If not, I'll be happy to shut down and over back to Grace.
Hello. Yes, thank you, Dr. Rex, and thank you, Dr. Sujit Jha, for that very elaborate session. So for the Q&A, Dr. Neeraj?
Yes.
Yes,
So I
you can
have few queries. As you said, Dr. Sujit Jha, there were many patients of yours, or almost 99 point something percent of patients are on vitamin D. So how frequently do you do the vitamin D test?
I don't do it. If they're taking it, if they're not convinced, then I do it. I just supplement them. I don't do it. It's a very
Even
expensive.
the younger patients or only the old patients?
Any patients above 18, I give vitamin D3. They come for thyroid, simple thyroid. They come for PCOD. I give them 60,000 DPRA twice a month regularly. Now, if I'm not sure if they're deficient, if I think they need to supplementation more, I can give them 60,000 EU every week for 6 weeks time, then twice a month forever. And there are studies from Professor Horlicks which has been proven that if you don't do vitamin D levels, if you go 120,000 unit in 3 months time, it comes to around 4,000 IU per day, you will not overdose. If you're not sure, give 60,000 IU once a month or 1,000 IU every day, you will be fine.
So in addition to that question, most of the calcium brands which we are getting now are masala brands. I would like to call them masala brands in Indian way. They have vitamin D3 2000 units. The most popular brands which are right now on the market is 2000 units of vitamin D3. Then there is 500 milligram elemental calcium. Then there is some hydrofolate. Then there is some methylcobalamin 1500 microgram. So if we are giving that, do we still need to supplement them an extra vitamin D3 monthly?
I think so. And then you check it. Once you're not sure about their masala brands, then Dr. Neeraj, I would rather do it because you don't know you can overdose it. And there are 3-4 cases with hypercalcemia, with pancreatitis I've seen in 20 years' time. So yes, when you are trying to supplement more like an orthopedician and we are trying to give more, it's worth doing at certain points in 6 months' time or 3 months' time, making sure we're not topping up and we're not sure about the absorption. Okay. I agree with that, yeah.
So Dr. Rex.
Yes.
Yeah, do you do vitamin D3 levels of all your pre-operative patients or you just supplement them? I'm talking about the osteoporotic fractures, the fragility fractures.
No, none of my patients get vitamin D tested because I believe as Dr. Sujit was telling that, you need to supplement them with a routine dose of 2000 IU per day. So I don't test them at all. Only patients, sometimes the OPD, if they have, unexplained back pain, neck pain or something, where we don't have an answer and the patient sometimes wants something wrong in the investigations, just for the psychological factor, I do a vitamin D and say, okay, you better take this, you may feel better. And the patients, they feel better, definitely. I don't know how it works.
So sometimes it also has a placebo effect maybe.
Yeah, maybe.
Yeah. So, yes. So Dr. Sujit Jha, when would you like to, when you give about the other drugs, that is denosumab, teriparatide, those type of drugs, would you then investigate their calcium and vitamin D3 in detail?
Yeah, if you have, if somebody had osteoporotic fracture, it's worth doing the calcium, phosphorus, PTH, and alkaline phosphatase in those cases because you may have primary hyperparathyroidism, hypercalcemia in that case. So it's worth doing that level. And that when you're doing a PTH level, it's worth doing vitamin D level at that time. And most preoperative tests would have calcium and phosphorus, majority of them, as a routine KFT, calcium. So it's worth doing that. I would say that, especially if you already had a fracture. But yeah, vitamin D supplementation can be given blanket, eye being closed. But once you have certain things happening with the vitamin D and calcium metabolism, it's worth doing that. So I would test them, investigate, and make sure they're not hypercalcemic, because there can be hidden hypercalcemia. The prevalence of hypercalcemia, primary hyperparathyroidism in above 65, could be 1 to 5%. So there could be hidden hypercalcemia, and with a fracture of radius can happen. So I think it's worth doing the testing at that time when you already had some event. It's like, a fracture or something. Is that the question, Dr.
Yes. I think you have answered it perfectly. So I have one case. There was this 45-year-old male working in municipal corporation as a sweeper, and he came to me with a history of fall at home. I felt that is a trivial fall. His hair was all white. He's my age. I am 43. He's 45, so 2 years elder to me. And his history was that he just had a fall. It was more of a trivial fall or high energy. It was very difficult because he was on a high stool and he fell down. And he had 2 fractures. This question is basically both for Dr. Rex and Dr. Sujit Jha. So he had a IT fracture, intertrochanteric femur fracture, and he also had a distal radius, just a hairline crack. But his bones somehow appeared quite weak. So unfortunately, by the time I could get him on the table and get his vitamin D and PTH investigated, I had already started him on vitamin D because I didn't want to take any chance. So what I got was a high vitamin D level, but a very low PTH. PTH was almost only 5. So do you think that this was because of the vitamin D3 which I had already supplemented, or it is generally low? What does vitamin D have an effect on PTH?
It'll go low.
It'll go
vitamin
low.
D, it'll go.
Yeah. Okay. So because basically it may be because of just the vitamin D3 that it has gone. For another doctor,
but why did he have fracture, Dr. Neeraj? But that's something needs to be investigated. A sweeper who's very active, roaming around and physical activity, and why did he have that? Needs to be that to 43 years.
I got his testosterone done also. I got his testosterone level done also, because that was the first thing which came to my mind. In fact, I had 2 things that if it would have come low, I would have asked his wife, has he stopped performing? Then I asked, what is his youngest child's age? Youngest child's age was only 5 years. So he had 3 children, and his youngest child's age was 5 years. So basically, he was quite active that way also.
Some of these patients, they may be on steroids for some reason. Did you find out?
Yeah, so he was not on steroids, neither was he taking any alcohol.
Okay.
I went deep in the history. He was with me for a good 1 week in the hospital, because with the COVID test and everything, the surgery was delayed by 2-3 days.
Okay.
He's fine now. His wounds healed very well. I gave him vitamin D3 and calcium, and that's all. I plan to do maybe the PTH again after 2-3 months, because I was almost going to start him on teriparatide. But then I took an endocrine opinion. He told, no, you hold on for 2-3 months. You have given vitamin D3. That's why the PTH has gone low.
Yeah.
So that is an interesting thing for all orthopedic surgeons. So if you have already given vitamin D3 and the vitamin D3 is high, your PTH may be low. So always investigate before you start Depura, not after you have started it. So Dr. Rex, would you, in a 45-year-old, consider putting him on zoledronic acid or anything, because it looks like a fragility fracture? I can even maybe trace his X-ray. I may have it right now.
Okay. I mean, definitely I would like to rule out secondary causes for the, osteoporosis. As you rightly said, you've been, trying to find out a reason why this has happened. And at the same time, you treat the osteoporosis like any elderly with the zoledronic acid, calcium, vitamin D supplements. Probably that is the first line of management, which I would think. So I will not straight away go for teriparatide. So let me see the response.
Can you see my screen, Dr. X?
No, I'm not able to.
Right now also? Just see. Grace, can you see my screen?
I can see.
Only Dr. Sujit I can see.
I can see the fracture as well. I can see that.
Yeah.
There is definitely a fracture there.
So can you see this bone? It doesn't look osteoporotic. The cortices are okay, but this area looks quite osteoporotic. I'll just zoom it for you. So I really don't know. Basically, see, these 3 threads are not there. So this looks like osteoporosis to me. I'm really basically very confused. And to have 2 fractures with just a trivial fall, sorry, that was not a fracture. 2 fractures with just a trivial fall is something basically which puzzled me.
And calcium levels are fine?
Yeah, calcium is low. Calcium is low.
So he may have hypopara, but hypopara would not cause this sort of fracture. Long-standing, because it says bald, autoimmune, vitiligo, hypopara, primary hypopara. His vitamin D supplementation may have caused his calcium levels fine, maybe. I don't know. So I think before you do anything, please ask your friend endocrinologist to investigate. Maybe a later or 2 months later, but this needs to be looked into. So he looks, as you're finding it out, I'm finding it out. So that needs looked into.
Okay. So I think that's all we have time for today. Grace, would you like to summarize?
I think, Dr. Neeraj, I have a question to you. What is this Ortho TV?
Yes, sure. So Ortho TV Online is a platform where it's a portal. It's basically a portal which we started somewhere in 2013. Then it was started by my partner, Dr. Ashok Sham. He's also an orthopedic surgeon. And in 2017, I met him. And that time, and he just did one conference on that, recording of one conference, and then it stopped. Then he met me in 2017, and in 18, finally, we decided to take it ahead. And so Ortho TV is a platform. What we do is that we put all these webinars. Right now, it's only webinars, but earlier it was full conferences we were doing live. Like it's a physical conference of orthopedic, which is happening like IOCON, Indian Orthopedic Association. We are going to do it live on Ortho TV platform. So it was like that. But now, because of the lockdown, it has grown exponentially. We have 13 to 14,000 registered members of Ortho TV Online itself. So what we do is we do this webinar live on YouTube and we put it on Ortho TV and we advertise it in all our groups. We have 27 Ortho TV groups of WhatsApp. Besides that, we have subspecialty orthopedic groups of around 150 more. So that is how we advertise these webinars, and that is how we have become more popular now.
Yeah, very good concept.
So I hope I have answered your question. Yeah.
Yeah, well done.
So
Doctor, well done.
Yeah, thank you very much. So Grace, would you like to summarize?
Yes. So thank you, Dr. Neeraj, and thank you, Dr. Rex, and thank you, Dr. Sujit Shah. It was a very elaborate session. Thank you, Dr. Rex, for taking us, our orthopedic surgeons, into the very minuscule surgery part. And thank you, Dr. Sujit Shah, for reiterating that vitamin D is very important. Supplementation is very important, especially to prevent and treat orthopedic osteoporotic fractures. So I think that was a very good evening that we had. Thank you so much to the speakers and all those who watched us today live. Thank you, Dr. Neeraj, and thank you, everyone. Thank you from Sun.
Thank you.